Okay, so this is our August 2025 installment of the Global Neurosurgery Committee of the World Federation of Neurosurgical Societies Research Group's Journal Club. And so today we are excited to welcome Dr. Hugues Dokponou from Benin, and then one of our subcommittee members, Dr. Alvin Ukachukwu, will be introducing him and will also be one of our panelists today. So Alvin, I'll let you take it away.
Thank you very much, Enes. And thanks, Hugues, for joining us today. So it is my pleasure to introduce Dr. Yao Christian Hugues Dokponou, who is a neurosurgeon from Benin Republic. He's an alumnus of the WFNS Rabat Training Center in Morocco, and also a neuroendoscopy fellow, also at Rabat. His academic credentials includes a university diploma in biostatistics, research methodology, and clinical research, and also a master's degree in epidemiology. And he's currently pursuing a PhD in neurovascular research. I must quickly add that Hugues obtained his medical degree from Ukraine. Dr. Hugues is a co-founder and past chairman of the Sub-Saharan African Future Neurosurgeons Association, which is a dynamic network of neurosurgery residents and young neurosurgeons who are committed to continuous medical education and research, and currently serves as the research chair of the Young African Association of Neurosurgeons under the Continental Association of African Neurosurgical Societies. He's dedicated to advancing neurosurgical knowledge and has built an extensive scholarly profile in that regard, especially advancing global neurosurgery in sub-Saharan Africa, and currently has over 60 publications as a witness. He's also a peer reviewer of several prestigious neurosurgical journals across the globe. The highlights of Dokponou's work is his leadership of the NEUTRIA Study, which is looking into the current state of neurotrauma research registry implementation in Africa. And that is what he's going to talk to us about today. So welcome again, Dr. Dokponou.
Thank you, Dr. Alvan. Thank you, Dr. Enes. It's a pleasure for me to be here today, and I really thank the forum, the WFNS forum and the global neurosurgery for what we've been doing. First of all, I want to acknowledge the privilege that have been given to me by the Continental Association of Neurosurgical Societies by allowing me to lead the research and the publication forum of the young CAANS. When you say young CAANS, you're talking about the neurosurgeon of the 55 African countries being graduated less than 10 years, you know. And we'll be working together, and this NEUTRIA study came up from our discussion. So as I usually say, is while discussing that good things comes out, you know. So before I continue, I will acknowledge, allow me to cite Peter Drucker, who once said, if you can't measure it, it doesn't exist. And what cannot be measured cannot be managed easily. And unless you measure it, unless you measure something, you don't know if it's getting better or worse. This is very important, because when we say a hospital is should be dealing with three things. When we're talking about a health facility, a hospital, we should see providing of care, medical care, treating patients, then training, continuing medical education, training and education, and then research. But it's one unfortunate that in most low and middle-income countries, mostly in Africa, we are more focused on one and a half, mostly providing medical care, little bit of training. I say a little bit because we all till now we still lay on sending our trainees to abroad for fellowship and all that. So we are dealing with 1.5. The third one is completely abandoned. Even I don't even think we are dealing with it for about 10%. I mean the research. So this is what we are looking into, and we got to a paper published by Dr. Barthélemy and co, where they pointed out this issue of neurotrauma, among the 16 countries in the whole world having this registry. Only 3 of them were reported to have a neurotrauma registry in Africa. And so what is a registry and why is it important? I will briefly mention it and come back to our study. That is the main topic of today.
And before you continue, I just want to make sure if you do have slides or a document or anything that you want us to see, you do have the ability to share, or if you're having any issue, let me know. If you don't, that's fine. I just want to make sure that you didn't have.
No, there's no slide. I just want to.
No problem. Let me know if at any point you want to share anything.
Okay, thank you, sir.
Yep.
So the registries are for what mainly registries are needed because we need to know what we are doing. We need to understand the limitation of things that we are going into. We need to appreciate the daily work we are doing. As I just said now, the research part is completely abandoned. So if you have the registry, it will help you to have a detailed description of individual sustaining TBI. You have to have to give in a given period to know how many patients you are treating. It will help us to define the population, to uniformize our definition of cases. We can also include all the subjects with TBI in a defined area. We can, with the registry, we can have a case identification from multiple sources, case evaluation by a trained team, of course. There will be a consistency in our diagnosis. With the registry, we will establish classification method so that when I'm in Parakou, in Benin here, I'm talking about a type of lesion in neurotrauma. So anyway, someone that is anywhere around the continent also should do the same. I mean, if you understand each other very well. And we can identify major causes, patterns, and mode of injury occurring within our populations. The registry will improve diagnosis accuracy as all subjects are weighted in comparison with good standards. So all these things, all these package things that the registries can help us to do. Why don't we go into it and do it well? It is not our fault either, because as a medical care provider, we are more trained to provide acute care. We focus on acute treatment of the disease, but the chronic disability that people have and how they live with that condition in long term have not been focused on in research. Very few countries and continents that are having this registry can deal with that. As a surgeon, I'm pretty good at predicting what pattern what a patient will look like after a brain and spine trauma. When he leaves the hospital, I can even predict what that person will look like when he leaves the rehabilitation facility. And I might say something about how he will be in 3-6 months. But beyond that, what I should be pretty good at is to know how the patients live with neurotrauma chronically. This is another aspect of what the registry can help us to achieve. And we are not actually good at giving the number of people living with neurotrauma. We cannot say it correctly. We can, to some extent, give the incidence of neurotrauma, the number of people that are admitted and treated for neurotrauma per year. We can give some data, but I mean, the new cases, when I say incidence, is the new cases of neurotrauma each year. We can give some number about that, but the prevalence of neurotrauma, I mean, how many people in African countries are living with neurotrauma? That number, we don't really have it. We don't really know.
Yeah.
That number is elusive. So
yeah, I want to add just to underscore your point, Hugues, because I think in the global neurosurgery literature, a lot of people are seeing numbers that we commonly cite for prevalence and incidence of neurotrauma, but you'll see that the methods in those studies, and I spent some time as a member of the research teams that were doing those studies, a lot of those numbers are modeled. They're modeled based on other data like road traffic injuries or things like this. And part of that is to address this gap that you're talking about. There's a major gap in real data to know what is the real extent of neurotrauma. And you can imagine when you're modeling road traffic incidents, yes, you're capturing a lot of the neurotrauma, but you're missing a lot of the trauma from the falls, from the assaults, from occupational injuries, and the many other forms of trauma, or even in systems. And you referenced my paper on neurotrauma registries in the International Journal of Health Policy and Management. I put a link to that in the chat as well for people who want to take a look at that. It's pointing to the roles of ministries of health, right? And the data they're collecting or should be collecting in their registries as part of a surveillance function. They often may not be capturing even all the road traffic incidents. So there's even a limitation in estimating the head trauma, using a surrogate like that. So I just wanted to underscore that for people who might think, oh, wait, but there are numbers for TBI in Africa. Well, where do those numbers come from? Not real data on the head trauma per se. So I'll stop here, but those of us, I think there are some people attending who are part of our current global coalition to make TBI a notifiable and chronic condition officially, and that's to help address issues like what you're talking about. So please continue.
Okay, thank you for that input. That's very important. It's true. There are data outside there, but how are they collected? How are they collected, and what the WHO is saying about this data collection and database stuff. So many things have been done, but the major thing we are focusing on is how we can informaze all this data collection. And I will jump into the study, to the NEUTRIA study. What I can say is that study was about the current state and challenges of implementation neurotrauma registry in Africa. So what are the challenges, and what is the current state of this? What is outside there? So the first thing we did was to carry on a survey to find out, and this was not easy at all. We were almost knocking on door by door to ask people to this form at different congress within Africa, at the CAANS Congress, to get the maximum part of it. But anyway, we got a good result. And the aim was to evaluate the availability, implementation, and challenges of neurotrauma registry across the continent, and provide recommendations for developing a continent-wide traumatic brain injury registry. So the study utilized the e-survey, as I just said now, and we got 91 participants, representing 39 countries, African countries, out of the 54. And
before you continue, I want to put a link again for the study. Make sure everyone who has joined, people may have joined late, I want to make sure they have the link to the study. And also, anyone, if you have any questions or comments for webinar attendees, please use the Q&A function to ask those questions so we can make sure to address whatever questions you might have. Okay, I've put a link in the chat to the NEUTRIA study as Dr. Dokponou goes into.
Okay.
All right.
Okay. All right.
All right. Thank you.
Okay. Thank you, Dr. Ernest, for that. So you can look through the study and see what I'm summarizing. I will just give a summary, and then if you have some questions, you can ask about it, and we will discuss. Mostly, we will draw together how possible it is, step by step, what can be done to implement this registry. That's what we should. All this discussion should base on. So briefly, we got some results, very interesting results, showing that right till now, almost 80% of data are registered, paper-based registries. 80%, almost 80% of paper-based registries, while 46% are still electronic. And only 7 countries have been reported to have a national registry. So then we provided some recommendations for addressing these challenges, emphasizing the need for government and stakeholder support, adoption of standardized framework, and the promotion of cost-effective electronic platform. So we also have we find out that there are some other data, some other gap that we can fill, but the data that we've got do not allow us. For example, we would have loved to provide some insights to reveal the significant gap between the prevalence of paper-based and electronic neurotrauma registry in Africa, but we don't have any data to provide to reveal that. Despite the global trends towards digital health system, the majority of African centers still rely on paper-based method. As you can see, this highlights the urgent need for technological infrastructure development in the continent healthcare sector. And additionally, the study reveals that only 7 African countries, have just said, are having a national neurotrauma registry. This also needs to be confirmed. This is a survey, and nevertheless, this underscores the vast potential for improvement in data collection and analysis across the continent. These findings have helped us to see concretely the critical importance of collaborative efforts, both within Africa and with international partners, because at the beginning, it wasn't. We spent almost 2 years before being able to put ourselves together to go with this survey. We had many meetings, even the challenges to carry on with this work as a group for the young council. It wasn't easy at all, but we happened to make it. We tried to make it happen. Some points to come up with. It will be point by point. What can one do? That's the question someone can ask himself. What should be done to be able to implement this neurotrauma registry? We found out about 10 points, 10 very important points that you can follow in case you want to implement this neurotrauma registry. We've seen together how important it is to have it, so that we can uniformize the definitions and uniformize the cases and the classifications and all that. We have a data that is accurate, that we can question at any time. And but how do we implement this registry? This registry will also, this is a very important part that I have not talked about. It will also help us to, it will allow us to come up with ideas that can help the care decision takers, those that are taking decisions for the healthcare policy in our country. Because when they don't have the information, they won't know how to handle it, how to go about it. This is a very important point also to remember. So what are the 10 different points? So the African countries face several specific challenges in implementing electronic Neurotrauma Registry compared to a paper-based system. So that's where we are right now. But what can be done? What are these several specific challenges? About 10 of them. The first one is the infrastructure limitation. Many African countries struggle with inadequate method, inadequate network, I would say, and energy infrastructure, which are crucial for maintaining electronic systems. Even today, in Parakou where I am, they have taken light twice already during the day. So this is a real challenge that we are facing. But nevertheless, it won't be something that can stop us to have an electronic database. About the resource, the second point is the limited financial resources and infrastructure are significant barrier to implementing electronic Neurotrauma Registry in a resource-limited setting. The third one will be the technical expertise, because there's a need for information and communication technology expertise to set up and maintain electronic system. And the fourth one will be internet access. Reliable internet access is a prerequisite for electronic registry. We all know it, which can be a challenge in many African countries. But many efforts have been done right now towards that in many countries. Funding the data subscription is the fifth one. The fifth one is the funding for data subscription, because database need some funding. Electronic system often require ongoing subscription, which can at times be costly for resource limited healthcare systems, which are already fragile for dealing with all these infection diseases. The sixth one is the staff training, challenge that you can face, because transitioning from paper-based data that you are collecting to electronic system require training the personnel, which can be time-consuming and resource-intensive. But the good news is that we came up with that in our discussion in this paper. The good news is that the WHO, the World Health Organization, has already proposed to us what they call the MDI, the minimum data set for injury. It has 7 components, 7 components, and easygoing, very easygoing. Let me see if I do have it here. I will show you. Yeah, this is where it is. The minimum data, data set for injury. Okay. Dr. Ernest, can I share my screen?
Are you trying to share, and is it giving you any trouble?
Let me see if I can. This minimum data set for injury is very important, and we need to have it. It's not easy going, it doesn't need any intensive training. Sharing us. Okay, I found it. Okay. Can you see my screen?
It's showing. Oh yes, it's showing an Excel with the
exactly
with the MDI.
Yeah.
Okay, very good.
Yeah, exactly. So because the data set for injury, let me see. Yeah, here we are. Yeah. I mean, I will show the raw data before coming to this one. here. Okay, so this is how it look like when you download it. The WHO data set for injury. It has 7 components, and these components are need to be filled. And this is what we have proposed in our discussion for that paper. If each department of neurosurgery in all the countries in Africa can lay on this 7 component of data set for injury, this will be a very good beginning for this the database for neurotrauma. And this data set for injury is the one they've used to write down the International Registry for Trauma and Emergency Care, the RETEC, which is used by neurosurgeon and orthopedist both. So this 7 components of a data set for injury is very important, and the SL file that I was showing is the one that I'm using right now. Let me bring it back. So you can see registry case. So that's 7 components. You can lay it down like this in a cell file for easygoing registry. For the patient registration, then you have the initial clinical condition. Then I can send it down if other colleagues want to have it. Details of injury. There are 7 components, and the 7 components are detailed down, and then you just fill it, and so on and so forth. So this data set for injury is very important, and we recommend that it should be used to implement to answer some of these 10 challenges. The 7th one is the interoperability. Let me see. Okay. Operationality. This is to be sure that data are consistently and interoperability across different electronic systems remain a critical barrier. I mean, when I register my data in this same file in my department in Benin, we're having right now 3 departments of neurosurgery, and if the 2 other departments are doing the same, it will be very easy for us to compare to bring together our data and just make it one. That will be our national registry. Very easy, and without needing many things to be done, and all this funding that can be needed to pay for the technological expertise. We don't even need to go into it. The 8th one is the resistance to change. Well, changes are not easy. When you want to bring something in a system, you will face many challenges. You will face many difficulties. That is well known. So changes are not easy. So resistance to change. The healthcare providers and policymakers may resist to transit from a paper-based to electronic system due to a low awareness to their benefit. Because I'm damn sure when people are aware of the benefit of what we are bringing to them, they won't refuse that, So they will definitely adhere to it if we take time to explain to them how important and the good things we can gain from this neurotrauma registry. And the workforce shortage. The workforce shortage, even if we face workforce deficit in our department, in our country, we can go ahead and handle this situation. We can find someone that is well motivated to do it. I enter the data myself, so you can have time. You can find time, even if it's 1 or 2 hours in a day, to enter the data about all the patients that have been received for neurotrauma that day. So that can be done. The last one is data security and privacy concern. Electronic system raise new challenges related to data protection and patient privacy that may not be a prominent with paper-based system. So this also needs to be explained in different countries. Why nowadays there are rules and regulations that are regulating this personal data security. So each department of neurosurgery, each neurosurgeon that is who is handling this kind of protocol need to lay on the local law of database security, database personal security. So these are the challenges, and at the same time the solutions that we can come up with to implement this Neurotrauma Registry. And I think it is easygoing and it can be done without any issue. So I will wait there for now and see if maybe there are some questions and we can discuss.
Yeah.
Thank you so much.
No, thank you, Hugues. I certainly have some. I'm sure Alvin may have some comments and core questions, and I want to make sure we leave time for you to talk to us a bit about the Research Methodology Training Initiative with young CAANS. So hopefully, 15, 20 minutes will be enough to address the questions, but we'll see. So first, I've put in the chat, some of the challenges that you mentioned in the paper, of which I'm well aware. You're very passionate about this topic, right? And so it's easy enough to imagine even yourself or colleagues close to you taking the extra time to collect this data. But so where I practice, and I practice in a trauma center that's actually a pretty low resource one in terms of American centers, okay? But even in my center, because it's a trauma center, we have a dedicated coordinator whose job it is to collect a lot of the quality metrics and trauma metrics that are submitted to a national database or national databases in the US for trauma care. And they include a lot of TBI data in that database. So can you speak a little bit about this administrative burden aspect, right? I know of colleagues, for instance, who, when they can get their residents to sort of take on an interest in trauma care as part of their research interests, then maybe the resident becomes the person who's interested in capturing that data for some period of time. But then they eventually have to go on to other aspects of their training and practice. So then it comes back to the issue, well, who is actually capturing the data? Who does this? It takes time, it takes resources. And I just to say it bluntly, it takes a salaried person, somebody who is, that's their job, and they are earning a living from doing it. So would you mind addressing this aspect and maybe talk about what's been happening in Benin and in your experience trying to get the 3 centers on board with this data collection?
Okay, thank you so much for this great question. What you describe is current, is what we are living on a daily basis, and you can appoint someone to take care of this data collection and show him how it works, and he start doing it, and for other reasons, he'll be forced to leave the department and go for something else. He may come back, but this cannot stop the data collection, because what can be done is not to have only one person doing the job. First of all, I say it right now, as far as I'm concerned, I'm doing it myself, and when anyone is able or is willing to help, he will jump in and we will let him to do. So that means whenever the person that is doing it is not there, I myself able to continue the job before he come back. And you are pointing out something particular about military teaching hospitals, where the personnel can be moved at any time, for mission, for many other things, I think for the other part in the Department of Neurosurgery, for the university hospital, they are more stable than with us, but we still do it. Okay, so that means at least 2 of them should be trained for this. I think 2 of them should be trained for this. And there is also today a possibility of mobile technology integration to leverage with widespread use of mobile device today in Africa by developing mobile application for data entry and management. And this can bridge the gap between paper-based and full electronic system. So this the SL file that I just showed now can be shared on the mobile device, and when the neurosurgeon on call should be able to fill the form. It doesn't take time. He's called to see a patient, maybe in intensive care or in the emergency room. After seeing the patient, just 5 minutes, he's done already to fill this form. So all these things need to be considered to make it more practical and easygoing. So that let us do it and let us not make it like this is another job apart from what we've been doing. We should make it inclusive in what we've been doing and to be easygoing. And the experience of Benin, I will say, I'm just coming back to my country. So I've met all the collaborators, the neurosurgeons on the ground, and we are trying to make something happen right now, but we've not started yet. We are still talking over it to see how. Even the other day, the head of department, who is the dean of the medical university over here in Parakou, he has proposed he has suggested to me to find time to come out and train the personnel first of all. So right now we are dealing with the preliminary things that need to be done to install this collection of data with the SL. So maybe in a few months I can come back to present the data and show how it looks like. Okay, thank you so much.
Yeah, that sounds great. Go ahead, Oliver.
Thank you very much, Dr. Dokponou, for that exciting presentation. And I really wonder if you had slides, how much more, you would have done. But that was an excellent presentation without slides, all off your head. So thanks a lot, Dr. Dokponou. And like Ernest mentioned, you are very passionate about this, and having neurotrauma registries, especially in Africa. And really, it's said that you can't, you cannot correct what you can't measure, so you can't. So if we don't have the ability to measure, to actually talk about the prevalence, the incidence of neurotrauma in a setting, then it will be difficult for us to, treat patients optimally. Yes, many of the guidelines that are currently in place, we adapt them, we apply them to our patients, but we do know that they are mostly developed, with high income settings in mind, without acknowledging the resource limitations, which we face. And that's why it's important for us to have the database to be able to also comment on what we are doing, what the situation is, what the challenges are, and what the local context is, and being able to apply that in, properly managing patients, it's really it will really improve evidence-based care, for neurosurgery patients. And you've told us about, the advantages, the benefits of having the Neurotrauma Registry, the challenges we currently have, and what we can do, to resolve that. And I do hope that I see a lot of people from different countries in Africa and beyond. And I do hope that as many people as have listened to you would go back home, with something, to that they have learned, also to put that into practice and to try and adapt that to their situation, especially the WHO. So we actually have a template that we can use, which is the WHO minimum data set, which you shared. And of course, we can modify that. And that's the reason why we need to come together, in Africa, put heads together, modify that, have a template that will be applicable to everybody, from the north to the south, from the east to the west and Central Africa, so that everybody will have the same sort of registry or database, template to use, and ensure that all the variables are collected, in the same manner. So once again, thank you very much, Dr. Dokponou. I am part of the NEUTRIA Study, and I totally support your efforts in that regard. With this said, I think we have, okay. Yeah, okay. There's a question from Dr. Rahim Bello. So Rahim Bello has talked about the challenges of neurotrauma and data care are obvious, and then has expressed some concerns. So one is sustainability of data collection. So from their experience, there are many missing data, non-filling of data, especially due to the heavy workload that people have. So there are few neurosurgeons, as we know, and there is a ton of work to be done. So many people may not have the time to sit down to enter the data in the registries. And that's why Dr. Dokponou talked about training staff to be able to do it, if since the neurosurgeon is very busy and unable to do it. Then the second one is that the WHO data set does not contain some relevant information that addresses gaps in neurotrauma care, such as imaging findings and availability of neurosurgical care. Yes, and that's why we need to adapt, the templates which they have given us. Dr. Dokponou, I know, Dr. Ernest, I think you also have some comments in that regard. Dr. Dokponou, Dr. Ernest?
Yeah, well, why don't we let Dr. Dokponou, if you want to comment on these, I certainly will add any thoughts, but would you like to address these comments?
Yeah, I think Dr. Avon has said it all. This is a template that the WHO has prepared to help us go uniformize this whole thing, but we need to adapt it to our own realities. We need details about the imaging. We just create a line and a colon and put it. So we need to adapt this table to what to our needs. And as far as in the same country, we come together to do it the same way. We will convince with time other countries to do it that way, because this. I think all the surgeons will be willing to add a column for details and information about the patient imaging, and patient those information. So the most important thing is to do it, to informatize these actions, to make it unique, so that from country it will be something regional, and then something for the whole continent. This is what we are doing. So I think it should be done. So thank you.
So my comments, and thank you. I agree completely with both of your comments. First of all, there are levels to look at, and I really thank Rahim Bello for these comments. I want to address both specifically in terms of the sustainability of data collection. I entirely agree. And let me just reread the comment or the concern. Sustainability of data collection. From my experience, there are many missing data due to non-filling of data, especially during heavy traffic workload. I think with respect to this is one of the many reasons why, in my opinion, it's very important to have a dedicated workforce for data collection, right? I mean, all of us who have done research in this space or in related spaces, or surveys and such, anything that where we were collecting data, we know how we can run into several versions of this, and there are ways to prevent it, right? In a survey, for instance, there are ways to make it impossible to submit without having certain aspects of the data collected. In terms of certifying centers, in the US, there are certain metrics that absolutely need to be collected and reported in order for centers to be certified. The bottom line is, if it is important to us, then we need to give it value, and money is a measure of value. And so you have to have someone paid to do this. You do. Otherwise, there's going to be a competing element, a competing value that is going to have some aspect of this data collection job sort of left open or incomplete or pushed aside in favor of something else that was more important. And, you know, I think part of the solution to this, so, you know, in the background, what we're talking about is how do you find the money to pay the person who collects this? Well, first it has to have value, right? This is tied into the importance of data collection at multiple levels. So I said earlier that there is now a global coalition that is advocating for traumatic brain injury to be globally recognized and recognized at the highest level of international health policy, right, which is what the WHO represents, as a chronic and reportable, a notifiable disease. Why do we say this? Well, if you look at global burden of disease data right now, traumatic brain injury is not represented as a distinct diagnostic entity. It's just not there. What you have is three broad categories of injury: communicable, non-communicable, and injuries. And then injuries are represented by mechanism. So we're counting road traffic accidents, we're counting falls, we're counting assaults, we're counting all the different forms of injury by mechanism, but we're not actually reporting at the international level the result of those injuries. So your TBI numbers are missing. They're sort of a cluster of different mechanisms that may or may not cause TBI, and there's a lot of heterogeneity even in the data that is collected. Okay, so what's the problem with that? The problem with that is when health budgets are being generated, how do you give value to a diagnosis that doesn't exist in your high priority diagnostic entities, right? If more people are being affected by TBI than people with HIV, TBI, and malaria combined, right? But those communicable disease entities are getting millions and millions and millions more dollars of funding in every version of funding you can think of than TBI. What's the issue? It's an advocacy problem. And, you know, advocacy takes recognition, and it takes people who have an interest in the area and expertise in the area to come together and teach the policymakers, who are mostly not neurosurgeons and who are mostly not TBI experts, to recognize they're missing a silent pandemic. And they're missing the pandemic's effect on many other disease entities they may care about. They're missing how much dementia is being created by traumatic brain injury. They're missing how much psychiatric disease. They're missing the massive economic toll that TBI is taking on their populations. But if we can start to bring that to the forefront and make effective changes to international health policy through effective advocacy, now we can start to get some of that health funding to move towards support for TBI. So all of a sudden, now a Ministry of Health that's looking at where they're going to be investing their dollars can start asking questions at their hospital systems, you know, to their hospital systems, and say, you know, how much TBI is showing up at your center? How bad is it? What do you need, right? Because all of a sudden now they see, oh, this is affecting our country's, you know, national income. So now this is what's important about having international standards for data collection. Those templates should always be flexible templates, right? The WHO data set, it's a minimum data set. It doesn't mean you collect only this data, but so that we can start doing some of this very important high-level advocacy, please collect at least this data. And if you have a very robust registry, and you'll see in my paper, you know, Andres Rubiano has led really extraordinary work in this space in Colombia, okay? You know, he's collected data elements that many, many American centers are still not collecting. I mean, consistently on TBI. They have a very, very rich data collection approach. I think that approach should inspire, certainly capture whatever is missing. That's the second aspect of Raheem Bello's comment. Many other gaps. The last thing I want to say about this, if you're interested, and again, I provide an American perspective, even though I have sort of a leg in the Caribbean because of my patient roots and engagement there, and a leg in sub-Saharan Africa because of more distant roots and connections. In the US, the National Institutes of Neurological Disorders and Stroke organized a workshop around TBI severity classification. We started to recognize the limitations of the Glasgow Coma score in categorizing TBI, because it was missing many, many aspects of what affects the severity of a traumatic brain injury, like some of what has been mentioned here, imaging findings, right? So for actually, perfect example, last night, I had a patient present with a GCS of 14. And we classically call that a mild traumatic brain injury. But my GCS of 14 had a right frontal epidural hematoma, a multifocal small contusions, and evolving subdural hematoma and traumatic subarachnoid hemorrhage. That's very difficult to think of as a mild traumatic brain injury. That's someone we're going to watch very closely, right?
Yeah.
Right. And there's a whole lot in the background with this patient also: seizure disorder, alcohol abuse, many other things. There's a social context, social determinants of health. So we're trying to move towards a model of TBI classification. And this is what this NINDS working group that I'm a part of has been trying to advance, is a new way to think about TBI classification and prognosis, and using the Glasgow Coma score for what it's intended for. It's only intended for as a gross assessment of mental status, not a neurological exam, and certainly not a classification of severity of injury, nor a prognostic tool. It's one piece of data that should be part of a more comprehensive classification we're calling CBIM. CBIM, C is for clinical data, B is for biomarkers. Okay, so we want to try to move towards using blood tests that tell us how bad the TBI is. So, if I had a patient with a GCS of 14 that had a GFAP level of 10, but then my patient last night had a GCS of 14 and had a GFAP level of 10,000, well, that's a very different kind of TBI with a GCS of 14, right? With a blood test that doesn't require imaging. And may end up being cheaper down the road. So we want to move towards biomarkers. That's a component. Imaging, I gave you the imaging characteristics. That's what the I is in CBIM. And the M, perhaps the most complex area, and this is where I focus a lot of my research, is the psychosocial and environmental modifiers of TBI, where all of the social determinants of health, the structural factors and discrimination, the limitations, the economic factors, a patient who doesn't have any psychiatric history that comes in with bilateral self-inflicted penetrating nail gun injuries from attempted suicide, right? That is a penetrating form of TBI with a major social context that was missing from that patient's history. But now the patient gets discharged with with schizophrenia and other new diagnoses, in addition to all of the clinical factors related to care. So that actually, I was involved with a couple of papers, one in Brooklyn, New York, one in Nigeria, with patients presenting similarly with what I just described, right? And this is the kind of thing that's often missing from how we think about TBI severity classification. So all of that is to say that the field of neurotrauma is moving, and we definitely want to think more about what should we really be capturing, which frankly should be much broader than the subset of data elements that we want to collect and use for very high level international health policy advocacy. So those are the comments I have to that. So thank you again, Raheem Bello, for that. Anna Silva says, congratulations, Dr. Hugues, for bringing light and first step on documenting neurotrauma in the continent of Africa. In the context of the challenges you faced, who or which entity would be the champion to drive the agenda in each country? And does the plan depend on researchers, or does it require an administrative role with involvement from the ministries of health? So I'll let you answer that.
Hello?
Yes, we can hear you. Go ahead. I'll let you answer that comment.
Was that a question for me? I think
yes, that was for you. Do you want me to reread it?
Yeah, please come again.
Yeah. Sorry. So it says, so the question is, in the context of the challenges you faced, who or which entity would be the champion to drive the agenda in each country? Does the plan depend on researchers, or does it require an administrative role with involvement from the ministries of health?
Okay, thank you. Thanks for that. Very, very nice question. We need to move forward this young generation, and not to wait for our politicians. And each person need to ask himself, what can I do for my country? I think this should be a starting point of what we can do to change this whole thing, because let me say, people have waited a lot for many times, for a long time, for the politicians, for policy makers, for government, and all that. But the main thing is changes should start from each department of neurosurgery. When each and everyone is trying to fill this minimum data set for injury, just those 7 components. Let's start from that. That should be okay for now. We can start from that for even 5 years and see how it goes. And without asking even a pen, without asking anything from any government, from any policymaker, we make this happen. We can do it, and the result that we will get from it will be the tool that we will use to show them that this is what's happening with TBI in your country. This is what's happening in this country for TBI. This is because in public health, for global neurosurgery, you cannot convince the policymakers when you don't bring concrete data. So to make it brief, no way to wait for politicians and ask for who is going to take out this, who is going to implement this policy. No, we are the one that will do it, and we will start. We have all the tools. We all have laptop. You all have computers. We have iPhone and any smartphone. We can handle it and do it. Having computer in the department doesn't cost anything. Doesn't cost anything. So each and everyone in his department can start implementing this filling form of the minimum data for injury that have been provided by the WHO. That should be the beginning. In less than 2 years, we should have concrete data that each and everyone can take, speak, and convince the policymakers. They will surely listen to him. They will surely listen to us. And from that point on, they can change how they distribute, how they dispatch this the resources that are allocated for health. Because when you take the feedback each country is giving to the WHO, so you will see that you will find anywhere is written the neurotrauma, traumatic brain injury. Nowhere. I've seen for the one of my country for 2023 and 2024, and only infection diseases, and the only one thing that is there for trauma, they put trauma, just trauma. And they put trauma 13%, something like that. I cannot tell which kind of trauma it is. Is this a spinal cord, a traumatic injury? Is it TBI? Is it a leg trauma? Is it fracture of the femur? I don't know. So we have to start this Neurotrauma Registries in our department without waiting for Ministry of Health, policymakers, or any other person to come and help us to do it. It's when we come to a point that we are able to have data that we can show, we show that, okay, come and see, this Neurotrauma Registry, this neurotrauma issue is killing the population even more than malaria. Maybe, who knows? this neurotrauma registry, this neurotrauma and this spinal cord injury, these two combined together are killing your people even more than this disease. In that case, we will convince them. But if in case we are not able to do this first step, we will be able to convince them. There is no way we will be able to convince them to listen to us and help us to implement this issue. After answering this question, I want to come back to what Dr. Ernest just said to add something to the example he had given brilliantly. What I wanted to add is the second part, the second branch of what he said. You know, there was this paper published by Tropiano and all in 2019, where they did the bibliometry analysis of all the publications about TBI available in the PubMed database from January 2008 to December 2018, 10 years. And they come up with a very nice conclusion. They say, America and Canada are having 4.6 million TBI cases per year, and they are publishing more than 400 papers per year. We in Africa, the whole Africa, we are having double of that. We are having almost 8 million cases per year, and we are publishing 10 papers for the whole year. You know, this was just recently, 2019. And when we are seeing this kind of data, someone should be, you know, it's a kind of, okay, what can we do? But what can we do? What should be done is to start collecting very well the data, start having concrete data well collected to be able to fill the gap. Because each and every one we tell you, okay, let's work, let's do some publication to fill the gap. Let's go ahead and publish something to fill the gap. No, you don't just come up with something and say let's publish something. This should be done from point zero. How are they doing to come up with good result, good paper, and publish those data to fill the gap? We need to work hard. We need to go ahead, not wait for any other person, and know that we are the one that will handle this situation. Because per countries where even when you take Europe, they are having, if I can recall very well, they're having roughly 9 million of cases of TBI per year, and they're publishing roughly 200 papers. We are having almost the same, where we're having 10 papers published in a year. So that means continents were publication. We that are having more cases, we are having a very few publications. So that doesn't make sense to continue that way. We need to change this thing. So to change it is to see how someone used to say doing good is start doing what others are doing very well. Start doing what others are doing very well. So this is, and I will jump into with that transition to the UCANS, because Dr. Ernest has asked me to talk about it.
Yes, and our time is running short. I would like you to, however, your confrère, Dr. Bankole, had raised his hand, and I invited him to join as a panelist. So if we can just let him, you know, unmute,
yeah, of course,
and share some, you know, his question or share some comments, and then and then maybe we'll jump into young cons, and see if we have anything left, any time left for any more questions.
Okay.
So Bankole?
Yeah, dear Dr. Barthélemy, I'm very glad to join you. This is I'm so happy that we come off this, and we are on this stage of this project since 2 years ago, and we cannot improve what we do not measure. That is our motto, Hugues and me, since many years ago. We should start from anything and try to do better than yesterday. So that is why we come off of this study, and we are doing our best to make it happen. I think that this stage it is that we should now move the steps, and the step is that we should start from our own, from each department. We join together and try to have a timeline when we could come each, I don't know, each 3 months to see, okay, I don't know, trimestry, something like trimestry, 3-monthly, meeting of TBI in Africa. Why not? There, some department could send us one of their representatives, as Dr. Anna was saying. It should be resident. It should be the chair of the department, or one of the neurosurgeon in the department, who will dedicate for the register of the neurotrauma, and then we try to see at the end of the year what is the gap that we feel, what we need, what is the challenge, and then we will try to fix that. And as well, after that, we could come back again and try to see the quality of the data that we got, and you will see we will see what we can do with that. And I believe that with Registry, we will be able to do a lot of study, a lot of quality paper we will reach out of this Registry, and that will help us for sure to have a quality data, a quality how can I say that, result that we can show to the policymaker. You can see that is what we did without your support, without a grant, or without a big funding. Of course, we need the funding, because research without fundings, I think that in Africa we should stop also this kind. We should also think about that, because usually we do it without funding. But I think that starting by noting and showing the result, we will get the funding, and we will make more than how can I say that, we will fill the gap of the other high-income country in terms of Registry, and maybe why not to move forward to the other disease in global neurosurgery, because you are agree with me that global neurosurgery is not just about TBI, but many of other diseases also is concerned, and we need to measure what we are doing in the continent and how we can improve that. And I'm really happy that Dr. Hugues take he doesn't manage his time to bring everything up at this stage with other colleagues that since 2 years we are working together to make it happen. Thank you very much, Dr. Alvan, for being there for us, and Dr. Barthélemy. I'm very happy that you joined the board. And I think that we will be able to do something great. And let's start, and let's bring now a timeline for the next 5 years, 5 months before the end of this year, to bring something out, and just let's start before this year to go to the end. Please, that is my concern right now. We should start. We should just start. Thank you very much.
Thanks so much, Dr. Bankole, and his points are very well taken. I'm all for it, and consider me, a willing collaborator. I think you know that very well, Dr. Dokponou.
Yes. Thank you very much, Dr. Bankole. I think there's one other question that Amma Haida asked. Amma is asking about how you record data. Whether you do that manually or you use Excel or Google Forms. I think you already talked about using tablets and iPhones and laptops. So I think that's maybe pretty much answered. But if you also want to comment on that while you're talking about the young CAANS, then yes. I think I see Dr. Mayowa Opara on the present. So Mayowa is the secretary of the Neurotrauma Committee of the Nigerian Academy of Neurological Surgeons. And I know that they've been working on developing guidelines. In fact, they published sometime in 2018 or 2019 about developing a trauma guideline for Nigerian institutions. I don't know if we have enough time to ask Mayowa to tell us more about their experience. But over to you, Dr. Dokponou.
Yeah, why don't Dr. Dokponou, tell us what we need to know about the Young CAANS effort for advancing research methodology training. In our 7 remaining minutes, we'll see what we can do. I'd love to get May on this if we can, but why don't we go back to that?
We should get May on this, because she is a capable co-chair of the Young CAANS.
Oh, perfect.
Awesome.
She has many she many roles in this. So
Yeah.
let me just I just need 2 minutes to talk about the Young Council, what we are doing, and you can get her. What to say concretely? We need to fill the gap. We need to come up with some new strategy to handle the situation. And you cannot ask someone to do something that you've not tried to help him to be trained for. You know, so we that's what we said. Okay, so it's very important to expose people to this research stuff, because research and publication has not is a field that is separate from what we are used to as a medical doctor. So there's something others use to say. They call it an early exposition, for research. So we need to expose. We need to allow all the young comes to see what we are doing and how we do it. And if they have questions, that's what all this Young Council for Research is about. And I'm the chair of the research committee for the Young Council. And we came together with let me share the screen and show you briefly. It will be much easier for us. We came up together with a program that we put in 6 block, and this program will be we already started to run it. We finished with the first module already. We have done the second one. Now we are heading to the third. So we have discussed with our colleagues and friends of the UNCANS on how to define the research questions and the method, framing your research hypothesis and all that. Then we handle the right time with the help of Dr. Barthélemy, that had helped us to generously invite one of the main speakers for that session. She was great, and her lecture was really appreciated. And we still open the link and look at the videos from time to time to see to learn more about what she has said. It was very nice. I want to talk about Dr. Taylor, Dr. Taylor, I think.
Yes, Dr. Tanya Taylor.
Taylor.
Yeah, she also did want me to add. So she is a linguistic and medical anthropologist, as well as a statistician, and she really enjoyed the time and said if you need any training or presentations on qualitative research methods, she'd be happy to come back. So let us know. And as you know, the American Society of Black Neurosurgeons is also very happy to provide you support. So we're working on how we can continue to support this effort.
Thank you so much. Thank you so much on that. Definitely, we will come back and ask her to come back again. So the next webinar we are heading to introduce data analysis, which are moving the skill to analysis statistics and the main statistics analysis and analytic statistics. And then we will do the 4th one, the 5th, and the 6th block. I think we come together. We thought we put this way because we believe that after going through this 6th block, and even someone that have not heard about research and publication should be able to learn something and start to work on it, because all these things can be possible when our friends and colleagues are willing to start. They are willing to put all these things in practice. So that's what I can say about the young council. We'll be working hand in hand. There is a committee for continuing medical education also. I'm the chair of the research committee and the committee of medical education. So we are interchanging the presentations. So this month it will be, last month it was for the research committee that we had the second block. Then this month will be for continuing medical education, and next month will be for research. So this is how we'll be handling the situation, and I believe we will be going forward with this until we come to the result we have been expecting. So thank you so much. Sometimes to allow Dr. Me to comes in.
Thank you. Yes, it's in our last minute here. I'll read off briefly. I had asked May if she wanted to join. She may be tied up. I don't. So I don't know if she's able to make any comments or join as panelists. But there are some additional comments and questions that were thrown in, so I'll read them off and try to address them as possible. Rahim Bello followed up. Thank you, Dr. Dokponou and the entire team of Global Neurosurgery. I also want to appreciate all my teachers on the platform. I will appreciate the spreadsheet if the spreadsheet can be shared for implementation. It is important we move to action. What I can do, Dr. Dokponou, in response to this and also any other relevant links is when this gets posted on YouTube, because I will post this video on YouTube, we can include any links in that posting. So I'm happy to do that. We can connect about how best to do that. Okay.
Great.
And then,
wonderful.
And then the next question, what are the ways one can be involved in the project of the new TBI classification system /work? Thank you. So a couple of things about that. First, the workshop I mentioned, that work has essentially completed, and the papers I shared have been published, but obviously it's the beginning. I'm sure there is a corresponding author that you can write to in the Lancet paper that I shared by Manley and colleagues. So I think that's one approach, or the corresponding author for the working group that I was in that effort, the Psychosocial Environmental Modifiers Working Group. So that's in the Journal of Neurotrauma paper by Nelson and colleagues. That's probably the most direct way. But obviously just using that literature. Oh, I didn't share the National Academies of Sciences, Engineering, and Medicine consensus report in 2022 that actually set this movement forward. That's freely available online. So you can search for the NASEM report. And we'll include that when we post this on YouTube. Billy McBenedict, Dr. Billy McBenedict posted, and I had mentioned him to you, Dr. Dokponou. I just met him on an ASBN meeting, and he will be an excellent and willing lecturer in this Young CAANS series. Okay, so I'm happy you're able to join us today, Dr. McBenedict. And he says, just a comment, research in Africa needs greater promotion and demystification. Too often it's seen as an exclusive domain for professors and highly academic individuals, leaving out many potential contributors. By making research more accessible and inclusive, we can unlock innovation and drive meaningful progress towards across the continent. So thank you, Dr. McBenedict, for that comment. And then finally, I have the project with Young CAANS is impressive. Please consider involving other healthcare professionals into this to make it more multidisciplinary for greater impact, such as physical therapy, neuropsychology, registered nurses. Okay, and that is the end of our questions and comments. We're 2 minutes past the half-hour mark, so we'll go ahead and conclude. Thank you for your participation. This has been an outstanding seminar or /webinar. Not surprised. So happy to have West Africa so well represented, and Benin in particular, which according to my DNA constitutes the largest component of my African heritage. That's common for Haitians. It's Benin and then Nigeria and then everyone else. is how my DNA came together. All right, folks. So we'll conclude this, and on wherever you found out about this webinar, social media channels and such, we'll make sure to share the link for the YouTube. For the recording. So
I want to say a very big thanks to the Black African Association of Neurosurgeons.
American Society of Black Neurosurgeons.
American Society of Black, exactly.
ASBN, yes.
ASBN. So thank you so much. Thank you so much. Thanks for the leadership. Mostly Dr. NS, thank you for the leadership. I know I disturb you a lot. Even at times I forgot that there's time difference. So when I write to you, I'm waiting for the answer immediately, and I call. I said okay. So thank you so much, and sorry if I happen to disturb your sleep. And Thank you so much for your leadership. You provide us with great lecturer, and I'm happy to read Dr. Mark Benedict comment. I believe he will be able to join us for the next research webinar. We are waiting for his reply, and many more will come. I believe many more will come to join us. Thank you so much for this invitation. Also, thanks a lot. Thank you, Dr. Alvan, for being with us, and Dr. Nudin. Thank you. Thanks a lot. Thank you all.
Great. All right, everyone.
Yeah.
Take care.
Thanks. Have a lovely day. Bye.
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 Bye. Nice weekend, everyone.